There are a couple of things to keep in mind when looking at the prevalence and natural history of ROS1 non-small cell lung cancer. The prevalence of ROS1 is about 1.5% to 2% of non-small cell lung cancer adenocarcinoma histology. It is predominantly adenocarcinoma histology. It predominantly occurs in patients who have a never or light smoking history, whose age tends to skew younger. Um, they tend to be metastatic, and like with many oncogene-driven lung cancers in patients with classically a never light smoking history, there can be a propensity for CNS metastatic disease. The prognosis for these patients is generally better than the overall population because we have really good targeted therapies we can bring to bear. Crizotinib has been the most extensively studied. It is also an ALK inhibitor. It's an ALK inhibitor, ROS1 inhibitor. Was initially developed as a MET inhibitor. In probably the most known clinical trial, which was published in the New England Journal of Medicine, response rates were about 70% with median progression-free survival a bit over 19 months. So highly clinically active. Crizotinib in other studies, progression-free survival was a bit less. Still highly active, PFS well over a year. There's entrectinib, which is a newer ROS1 inhibitor. It's also an ALK and NTRK inhibitor, recently approved for ROS1. Its duration of response in an analysis of ROS1 patients treated in multiple clinical trials with entrectinib was over 20 months. There's also a drug, ceritinib, which is approved as an ALK inhibitor. It's not quite as active as alectinib or brigatinib, and it does have some more of a toxicity profile. It does have some activity in ROS1 as well, although it's unclear whether it has any benefit over the other, over crizotinib or entrectinib, and may have a bit less activity in ROS1 than compared to ALK. There's newer drugs that have been studied with activity, such as lorlatinib and most recently repotrectinib. I think for practicing clinicians, something I want to emphasize that is a common question I get is, can you use alectinib for ROS1 because it's a potent ALK inhibitor? And the answer is no. Alectinib is an ALK inhibitor and it has some RET inhibitory activity, but it really has no ROS1 inhibitory activity, so it's not a ROS1 inhibitor. That's a question I get sometimes, and just want to emphasize that. But there's a spectrum of drugs in development for this uncommon mutation, but one that we detect quite frequently in patients who have a never or light smoking history.